We shall now go on to our guest speaker, Dr. Barbara Parolini, who is a vitreoretina consultant, a very prolific one at that, from Verona, Italy, and she heads the Department of Ophthalmology in her center. And she is going to be showing us a fantastic array of images to the wide field OCTA coming of ages. On to you, Dr. Barbara.
Thank you, and thank you for your kind invitation and allow me to explain about what I found in this great topic. I have had wide field OCTA since 2 years, so I had the opportunity to try it on a huge variety of conditions in the retina, choroid, iris, and conjunctiva. You all know about the standard field. We've seen a wonderful presentation showing the advantages of angio-OCT over more invasive techniques. So we can extend the same concepts on the peripheral retina and open up the indications. So this is a normal wide field angio-OCT of the superficial capillary plexus. But the question is, to which extent with wide field angio-OCT can we avoid fluorescein angiography and ICG? First of all, what do we want to know from fluorescein angiography and ICG? We want to know about ischemia, about leakage, and about the presence of abnormal vessels in the retina and the choroid. So can we study ischemia with angio-OCT? In cases like this, we don't really need to, because it's evident from the color picture that this is a chronic ischemic case, and OCT angiography can only confirm what we already see from the color. Even in this case, we might guess that this is a non-ischemic case of CRVO. There are limited hemorrhages in 3 quadrants, visual acuity 0.4 decimal, and there is no relative afferent pupillary defect, so probably not ischemic. And with angio-OCT, we confirm our hypothesis. We used to struggle to know about ischemia using functional and anatomical signs, which were not so sensitive. And now we have all this imaging. And judging this image, would you vote for ischemic or non-ischemic? We have no time to hear your answer, but we have heavy hemorrhages in 4 quadrants, soft exudate, vision is 2200. We have a relative afferent pupillary defect, so we would vote for ischemic. Infrared is of no use, nor autofluorescence, the blue and the green. And with wide field angio-OCT, we surprisingly see there is no sign of ischemia. In one click, we have the answer. The main problem in this case is a CME that is resolved just with 1 injection of anti-VEGF. 1 month later, you can see no edema, no vascular dilation. Even the hemorrhages are gone from the comparison with the color picture. This is a different case of a 47-year-old woman. This is the good eye with the normal angio-OCT. In the other eye, she has a CRVO partially treated. We can see ghost vessels in the temporal and nasal quadrant. So we might think that she has some degree of ischemia. Vision is 0.3. And the central OCT is not so bad if we judge the external retina. So why only 0.3 decimal vision? The angio-OCT gives us the answer. Even more, the wide field angio-OCT showing the extreme thinning in the temporal quadrant. But I think the most striking answer is given by this picture that offers us the real extension of the ischemic areas. And we can superimpose the images to have a better idea of the latitude of the problem. In this 55-year-old male, we had this problem of very precise recurrent CME, precise like a clock. 8 weeks after each injection, he had a recurrence. So we thought about peripheral ischemia. The central OCTA basically told us that there was no ischemia, but not even the wide field OCTA. It was only the ultra-wide field image of OCTA that told that there was a significant ischemia in every quadrant, but only in the very far periphery. So we knew we have to move on with the PRP, and you can see here the partial PRP already done. On the NFAS on your right, you see the signs of the PRP laser. This patient was studied in the iris with OCTA. We are looking into the study of the iris vascularization as well. So this 92-year-old woman was affected by late-stage AMD, and she came one day telling us that she had a drop in vision in the left eye, but the color pictures that told us that she had AMD. But she passed from 2200 to hand motion, and it was the OCTA that gave us the answer. This is the OCTA of the right eye, and this is the OCTA of the left eye, the one with drop in vision. So we can see there is no circulation in the retina. She had a central artery occlusion, and that was the reason for vision drop. Can we also study leakage with angio-CT? Well, in cases like this, we don't really need to study leakage. We know the management just from the color picture, and the OCTA can only confirm our choices. But in cases like this, color and OCT were not so helpful. She was 20/20 at the time with barely visible CME, but with angio OCT wide field, I could see ischemia and new vessels, so I advised for injection and PRP. And surprisingly, only 9 months later, she was partially lost to follow up. She had a very, she came back with a very severe situation, huge ischemia and extensive neovascularization everywhere. So in leakage is helpful to tell us whether we are looking at a neovascularization or shunts. Look at this branch vein occlusion. From the OCTA only, we don't know whether they are new vessels or shunt, but if we combine B-scan with OCTA, we look at the level of the abnormalous vessels, so we know which are new vessels and which are shunts, and we know the management. So we can indirectly study the effect of the leakage. Very challenging is the study of the choroid more than the retina with the angio-CT. I focus my attention on autologous choroidal transplant and choroidal tumors. So this is a case of choroidal transplant that I operated 12 years ago. She still retained 0.5 decimal vision. You can see in the B scan the patch of choroid in the macular area. Fluorescein and ICG are telling us about the vascularization of the patch, but then again, I can see the same result in the OCTA. This is the wide field OCT, although the vascularization of the patch is offered by the central OCTA. From the peripheral OCTA, I know that the peripheral vascularization is appropriate. And even in this case of high myopia, I want to show you this image because you were asking about high myopia and segmentation. This case has a very huge, deep staphyloma, but as you can see, you can obtain a good OCTA telling you about the vascularization of the patch, the atrophic area nasal to the papilla, and the vascularization on the harvesting side, on the temporal side where you have bare sclera and just retina on top. So yes, we can have all the information we need from OCTA. In tumors, I know it is crucial to reach a good differential diagnosis with a long list of different parameters for multimodal imaging. But if you look at cases like this, you can see that the amount of information offered by wide field technology. This patient came 20/20 vision, asymptomatic for just regular checkup. I found that lesion, and I studied that with autofluorescence, SLO, and wide field OCT which is showing subretinal fluid. I knew the diagnosis just by looking at these images. Of course, she underwent fluorescein angiography, ICG, ultrasound, but I think most of you could guess the diagnosis just from this list of imaging. This is pre and post proton beam radiation. This is a very similar lesion, but when we go to we can see the subretinal fluid sign from autofluorescence, SLO. When we go to wide field OCT, we see fluid in the macula, intra and subretinally, and fluid on the retina on top of the lesion. And the wide field OCTA is different. We don't see anomalous vessels. We actually see dilated choroidal vessels, which are more silent than the previous case. This is the NFAS showing the intraretinal fluid. So a diagnosis of benign congenital angioma was done. She was treated with PDT, and this is pre and post treatment. This is just a list of very peculiar choroidal lesion. My message is that I think with improvement in wide field technology, we might avoid more invasive techniques. And so I want to conclude with this beautiful OCTA of the choroid showing you the vortex vein and all the choroidal circulation. Thank you.
Oh, that was a superbly wonderful talk, Doctor. I mean, I'm so glad I was here today to hear you talk.
Thank you so much.
Thank you. Thank you very much. Dr. Srinivas?
Yeah, Dr. Barbera, a fantastic talk. And I've seen your videos in the APAO and APVRS as well. Very beautiful. So my question still remains on this choroidal autologous transplants, the choroidal RP. And you have shown a beautiful videos of getting the vascularization reset back again. But still, what about the visual acuity in these kind of cases? And why do we not see much of visual improvement? Though we see, I was really amazed to see that video, how nicely it has got integrated, and so nicely you can see that it's got interconnected and it's totally vascularized as
on purpose. Thank you so much. On purpose, I selected a very old case, 12 years of follow-up, still retaining 0.5 vision is not so bad, 0.5 decimal, not so bad. So half of the patient can reach reading vision, and the improvement in average is 2 lines of visual acuity compares with baseline. And I found out that is totally about case selection, as often happens in our surgery. So this surgery works only if the external retina is still present preoperatively. Otherwise, it doesn't work, and you will not have any functional improvement if you are operating patient without photoreceptors and with late stage disease. So this is the pros and cons of this surgery. You have to operate cases which are not end stage. And these are usually the patients that are operated. That's why colleagues think that the surgery doesn't work, but that's not true.
Dr. Jay, one word before we go on to our last speaker.
Fantastic presentation. I don't want to spend time in praising how well it was. Just a quick question, Barb, that did you see any choriocapillaries on your OCT angio post-surgery? Because the large vessels can be there because they were already there. But I would be really interested to see that by putting the choroid graft, did you get chance to actually image the choriocapillaries in that area? But that is going to define the visual acuity improvement.
Yeah, you can go through the whole layers as you do in normal study of the choroid. When you do the segmentation, you can find the whole layer. What I'm transplanting is a full thickness patch. So what's left in the harvesting size, bare sclera, you transplant the whole thing. So it must be there, otherwise it doesn't work.
Very interesting. Thank you.
Jay, which machine is this? Is this Plexilate?
Must be Plexilate, right, Barbara?
Must be.
Which machine is this?
It's so the machine was OCT, the Canon Xefilio, and yeah, and the S1, and the color picture are from Clarus Zeiss. Yeah.
Okay, thank you.
Great
Canon.
picture.
Canon. Yeah.